there's very good evidence from overseas that, certainly in hepatitis C, that community treatment is just as good as specialist-centred treatment. So we can do it. And what we've got to think of is that, 30% of people referred to hospitals don't even get to their first appointment. There are many people in the community. We have a certain number who do get through the hospital system and they're effectively treated there, but we have many people in the community who are not. If we think of people living in rural areas, especially with hepatitis C, if we think of people who face stigma and discrimination in our healthcare system, in especially people who have injected drugs or are actively injecting, we need those people to be cared for in the community in services that understand them and can provide the proper care for them. And if we're serious about treating people with hepatitis C, we've got to stop just funneling them through hospitals. We've got to have treatment in the community.
Clearly this is both a federal and a state issue. There are state or jurisdictional workarounds which have been implemented in New South Wales, the ACT, and about to be worked around in South Australia and Northern Territory, but Victoria has not done this yet and seems unable to actually, get across the line in terms of actually putting these workarounds in place. These drugs, so particularly talking about the Hep B drugs, they are safer than paracetamol, okay? It is not a hazard issue. We know that 2/3 of scripts for HIV antivirals, which is a lot more complex than Hep B, are prescribed by general practitioners in the community. Furthermore, for the jurisdictions to shift people out of hospitals and into the community, that saves our Victorian hospital budget. It's putting the resources of the federal government at the availability of patients to be able to get this treatment, as opposed to making people queue up for hospital appointments, wait to see expensive specialists like myself and yourself, and also to queue up at hospital pharmacies for an hour or two to wait for their scripts to be filled every 2 months. It's craziness. So these regulations can readily be achieved. It's already in place for HIV. GP prescribing for HIV is already in place. The models are there, the training's there, it's been delivered for several years. Both yourself and ourselves have delivered these courses to GPs multiple times in Victoria and New South Wales. I can't believe we're still having this discussion.
There are impulse from the Commonwealth in relation to the regulations surrounding these drugs, and you highlight, Ben, very clearly that HIV dispensing has been broadened, and certainly the government is in discussion with the federal government to enable that to occur in relation to hepatitis treatments. It seems common sense, and we're certainly working towards that. I'm sure the Working Party will have a view on that as well, and when those recommendations come through, obviously that will all be looked at and prioritised, but as I said, it seems common sense to be able to expand the treatment of hepatitis drugs as has been the case with HIV.
And in treating hepatitis C, Fran, can you write that initiating script?
No, I can't. It's very frustrating not to be able to do that. In instances where a patient does not need hospital specialist assessment or ongoing monitoring.
And the reason is you've got an activated, affected community who actually have leadership of management of HIV. Hepatitis Victoria received $0 under the previous Labor government for Hep B related work, and they're currently receiving $0 under the current Liberal government in Victoria for Hep B related work. So you cannot have an affected community who can take leadership if the peak organisation representing the interests of that community received $0 per annum for specific Hep B related work. So that's the root cause analysis. We don't have an affected community who is taking leadership of this response, and we do not have a political environment which is allowing that affected community to step forward and be resourced to do that. There are workarounds for Hep B currently being implemented in New South Wales, the ACT, and about to be set up in South Australia and the Northern Territory, including the use of nurse prescribers for Hep B antivirals in the Northern Territory. That's currently happening right now by changing the regulations at the state level to allow hospital pharmacies to give them a list of accredited prescribers who have completed the training rolled out by the Australian Society for HIV Medicine, who do it in New South Wales, just like Networking Health Victoria do it here. They're getting a list of those providers, and they are then able to continue those scripts through hospital pharmacies. That's happening right now today. What Victoria could do at the federal level is to charge Victoria's representatives to the Bloodborne Virus and Sexually Transmissible Infections Subcommittee, BBVSSS, to lead the effort from Victoria at the federal level to say, we need to change this as a nation. Victoria will take leadership of this, and we will organise that. We will develop the pressure on the federal government to change it immediately, and all the jurisdictions will fall into line because it will save lives and at the same time save the jurisdictions millions of dollars a year.
Well, if we were asked to do that, I would have said yes.
I do want to echo Gavin's comments about empowering communities into action for hepatitis B. And the communities affected include Indians, Africans, the Eastern Mediterranean, Middle Eastern, and 1 in 10 of these people will have hepatitis B, and over half of them won't know about it. And from a personal experience, I see patients like Ross. I see patients in their 40s, 50s, Asian patients who come in with liver cancer, and their liver cancer is 10 centimetres in size, and I know within a year they're probably going to be dead. And our transplant waiting list, 20% of our patients on our transplant waiting list die on that waiting list. So it must be a multifaceted approach. So Australia has the lowest transplant donation rates in the world, and it all comes from community awareness and action, because these patients who I told them they've got a serious diagnosis and they're likely to die from it, they tell me, how come I don't know about hepatitis B? How come I didn't know? How come it's almost 20 times more common than HIV? How come there's not a media almost outrage that nothing's been, not nothing, but very little is being done about it?
Are we stuck with piggybacking on the HIV drive over the last 30 years, or is there some capacity in the system for funding hepatitis B? Colleen.
I wasn't going to answer that question, but I just wanted to take it back one step, and I think what I need is a background, a letter from Hepatitis Vic, so I can take it to Richard Di Natalia, our federal health spokesperson, who's also a GP and has worked in this area. But I think, I now understand a little bit more about what the barriers are, but I think it's one that we could all take up.
The Victorian Minister is having that dialogue at a federal level. Clearly there is a need to enable people to have greater access in their own communities. I grew up in regional Victoria. I know the barriers for some of those people, and we've got massive issues out in country Victoria. And certainly, in fact, Colleen and I are currently sitting on a committee together where we are looking at some barriers in relation to community pharmacy and dispensing. So it is all tied in, and we are looking closely at these issues to try and enable greater dispensing and enable people to access the drugs. So can I assure you all that the Victorian Minister is taking this issue seriously in terms of dollars and commitment, and we certainly encourage and applaud the work of Hepatitis Victoria. There is a lot to do at a community level. There's not one GP, there's not one type of community, there's not one type of practice. We need adaptable services, we need resourcing, and we need ongoing education and support. And then GPs can do it. We do a lot of cholesterol tests, we probably do way too many vitamin D tests. There's a lot of tests out there. GPs can test. There's good evidence GPs can test. They just need to know what they're doing and how to do it. And that can happen.
I might speak very generally about the type of model of care that would be involved, the diseases, the affected population, how they're distributed. The aims of testing, rapid testing for HIV and hepatitis C would be very different. For men who have sex with men, the primary aim is to enhance frequency of testing, to reduce undiagnosed HIV and to reduce transmissions in that way. I think rapid testing for viral hepatitis, or for hepatitis C, is more around accelerating an appropriate testing algorithm for people to ensure, to limit loss to follow-up between an antibody screen and a PCR. And at the moment, I think the typical trajectory of someone, particularly someone who's an active person who injects drugs, is that over the course of their injecting career, they've probably been exposed to multiple antibody tests for hepatitis C and have never received a PCR follow-up. And that's largely, partly the affected population, partly, the lack of ability to follow up, and partly a health professional education issue. Simply the rapid testing process itself, which involves, a 10-minute incubation period, provides an amazing opportunity for peers to talk to each other about sexual risk and about reducing risk and HIV issues in general. And we've had several clients talk to us within this evaluation about how the testing experience, A, is like talking to a mate about sexual health, but we also know that particularly young MSM do not talk to each other about sexual health in the community. But this provides an opportunity for them to talk to a peer about the issues around HIV and HIV vulnerability. And second, they say, you know, these are not the conversations you can have with a GP either, particularly within, you know, a 6-minute consult or in a situation where they feel comfortable, you know, discussing sexuality and their sexual practice with a GP. I think rapid testing would be fantastic, particularly with the new DAAs coming online, to accelerate opportunities for appropriate models of care and for appropriate care plans.
I'd just like to echo, I guess, everything that's just been said in terms of the benefits of embedding rapid testing within an environment where we're already engaging with the target populations that we might want to reach, and where we have really good relationships with those people in terms of working on health education and safe practices in relation to injecting. So therefore we would be able to also discuss rapid testing and Hep C and how we could be working with those communities to spread the word around the community in terms of safer using and the benefits of rapid testing and the benefits of treatment.
You know, for me, the ideal outcome in a trial like this, not simply how many have been screened, how does this facilitate an actual model of care so that, you know, a lot of people don't get where, you know, Ross got to, that there's an appropriate model of care developed, you know, early after diagnosis and appropriate monitoring of you know, progression of disease. For a relatively modest amount, particularly, you know, in the integrated within existing services where we can leverage off existing capacity, it is largely around the appropriate collection of data and then you know, using the resources available, either state resources or Commonwealth resources, to ensure that you know, appropriate models of care follow. So that can really be integrated within the costs of the system itself. So I would think you know, we could work up something relatively modest.
So I can't.
So I made it invisible in terms of the cost.
So how much was Pronto? How much was Pronto?
I don't know. Is that,
1.2 million.
1.2 million. So there's a figure. 10 times as many Victorians die of hepatitis as do of HIV. But if we start with 1.2 million, there's a figure to go with.
in terms of the concept, though, are there any other barriers? And then I'll come to you, Ross. Are there any other barriers in terms of the concept of rapid testing for hepatitis C at a government level?
Well, in fact, in my original presentation, I said the concept totally makes sense and should be rolled out and integrated. So I've already volunteered that to you. I totally accept it.
I think everybody agrees with the concept, but it's my understanding that there's no licence here in Australia, and that has to be undertaken through the TGA. We have very strict regulations in this country in relation to things like this. So if there was any testing that was to be undertaken, it would have to be done in a research centre such as the Burnett, Mark, and have those appropriate ethical considerations at that time.
I would echo those. I think it's a logical thing to do, but obviously the pilot has to be done first. But we should be doing this work, and we don't spend enough money on preventative health.
Ross, is this something that would have made a difference to you?
I'm talking actually about what would make a difference to the public purse, since we're throwing numbers around. I'm not going to talk about the personal cost to sufferers and their families, but all up, my treatment over the couple of decades would have cost well over $1 million. So if we're talking about 20 odd bucks for a test, let's get real.
I just wanted to raise the point that I think one of the great advantages of the point of care testing is that you can actually start to develop models that are outreach based, and that if that is combined with needle and syringe exchange, that you will get additional benefits in terms of prevention on an ongoing basis.
I work as a sexual health and bloodborne virus nurse at the Victorian Aboriginal Health Service, which is a community control program. And we do a lot of testing for hepatitis B and C, and we have significant numbers, and especially of people that are not vaccinated. And some of the comments I'd like to say around that is that, yes, we can immunise people at high risk, but people don't always identify those risks, especially. Also that someone said to me once, you know, if you've got someone who's 40 and doesn't have high risks and things like that, I think the pool of hepatitis B is higher within that age group, and if they're sexually active and moving into other relationships, you know, they're at high risk, but those people are more likely to, you know, they might not normally develop liver cancer and things like that, but when you've got diabetes and other sort of burden of illness as well, it's really significant, and we try and prevent hepatitis B as well. And that our statistics show that people will immunise if it is offered, so, you know, we have great rates of people being immunised if we're allowed to offer it to people.
So I guess, you know, with access to vaccinations, for us, one of the concerns that is there are a number of gaps. So even though we're increasing who we give it to, there are still gaps that we need to be, you know, really mindful of. So we need to sort of, irrespective of what people's visa status is, irrespective of when they came, because we've got established communities as well, and how people came is a really fundamental thing to getting those you know, risks down, and also as a preventative thing for the broader population. And when we're looking at mobile populations as well, which have traditionally been excluded, they're a high risk group. They have sex with other people in the broader community. So, you know, this is a group that we need to think about, and in particular, maybe international students, where 1/3 of that population group ends up living here forever, makes Australia their home. So this is a gap that, and currently there is no funding available to address this cohort group. So I guess from our perspective at CEH is we would like to see some sort of commitment towards working with mobile populations and an extension on the work that we currently do to ensure that the social marketing that we get into those communities is current and ongoing.
If I see a young person from a community which has a high rate of hepatitis B and they are non-immune, I can't vaccinate them yet at the moment unless I know they are a close household contact of someone living with hepatitis B. Clearly this is a young person, sexually active, at risk, likely, possibly in their future to have sexual relations with someone else who has a high chance of having hepatitis B. It's really a no-brainer. We should be able to vaccinate people. Certainly Aboriginal and Torres Strait Islanders should receive vaccine. It just should be easy. If we've tested someone for hepatitis B and they're susceptible, they need the vaccine. By definition, they're at risk. The Australian Immunisation Handbook would advise that we vaccinate them. We should be able to give it for free.
It comes through whenever we talk about these illnesses that there is a persistent stigma and shame, perhaps even more than HIV, that has persisted over the 30 years. One of the questions from representatives of the Victorian AIDS Council is directed to the major parties. What could you propose to increase support for people in this group around the area of stigma and shame?
Well, I actually think shared knowledge is the starting point. So shared knowledge in relation to the evidence. As Chris actually talked earlier before about the fact that many of his patients who come to him have got no idea, it's just come from out of the blue. Ross's actually journey was a little bit apprehensive about what his risk profile might be, some issue that he may not have wanted to know about his health status. So in fact, there's either a lack of knowledge of the prevalence and how the spread of disease can occur in a community. And how proportionate it is. And interestingly enough, there's a bit of distress in this room that in fact HIV, when it's actually, I'm not actually saying this explicitly, but in terms of proportionality, in terms of health risk, that in fact there's a lot of high profile attention that's given to HIV, but not to a broader condition that has broader ramifications. There needs to be a strategy in place that not only deals with hepatitis, but actually has to fit into a broader regime of what the public health issues are, what the population-based health issues are, what are the service gaps that we need to address. So they all should be part of a consistent, coordinated frame, and we've got a bit of a challenge to do that.
I take on board comments you've just made there. I think when I was training in the Alfred in the mid-1980s, the stigma around HIV and AIDS was phenomenal. Many of you will remember that, some might be too young to recall that. They've come a long way. We've come a long way. We've got more work to do. I think we can do it. The HEP Hero programs, the work that you all do, I'm sure we'll get there. Keep going.
I think there's a dozen other programs that have dealt with the issues of stigma around a range of things, but I too, like George, I'm old enough to remember the beginning of the HIV epidemic, and I think it was the fight back from the communities that said that this is not acceptable. But within that fight back, there were groups of women who were particularly affected by the stigma, and it was almost this innocent, guilty person and how they got the HIV, and people always wanted to know how it happened. And so, but I think we can learn lessons from those campaigns, and especially about the community itself has to take on, and people like Ross being able to explain what it all means is incredibly important.